So I have no disclosures, unfortunately, but that is due to the transparency regulation of our company, which owns the hospital as well. So I will give you in the next 20 minutes an insight how we start, or how it started, how important it is to build a team, the German experience, and as I said, our own experience, how we did that. You all know that was the first publication, everyone is aware of that, and you all are also aware of that was an emergency case. And of course, the procedure was successful, done in 2002, but the patient died 17 weeks after that due to non-cardiac causes. But now we have the guidelines, the European guidelines for the same procedure, who state that if you have high risk or let's say intermediate risk patient, you see that here, and you have a discussion within the heart team, you can decide if you will undergo a surgical aortic valve replacement or a transcatheter aortic replacement. So that is 16 years after the first in man, let's say, human experiment. So we started at the Heart Center at 2005 of training in the animal labs. And then, that was at the end of 2005, the former head of cardiac surgeon, Professor Moore, he came to me and said, yeah, now we will go for human. And I had my round with my senior consultants in December 2005, and I asked, okay, who will jump in? Who will do that? And I have 10 senior consultants, and there was silence in the room. So, and then I said, okay, if no one of you will take that, I will do the first one, and then we will see, and then you jump in. Fortunate for us, it was successful. So the first one was performed in 24th January 2006. That was a transfemoral, and the second, or the first transapical was performed 16 February at that time. And then in 2006, remember that there was no CE approval during that time. So that was really for research. But then two of my senior consultants, luckily for me, they jumped in and they developed the program. So, and that was that picture of our first hybrid OR, which was renovated this year. So you will see several slides after that, the new one, where we have that C-arm and all that. And we start to build really that team approach. So meaning cardiac surgery, cardiology, and cardiac anesthesia. They were really one team. And for the beginning, that was a very small team. And I think that beginner team was really a balanced team. So, and I think that is what I want to emphasize. We have three different disciplines. The cardiac surgeons, they are used to work with us, or we with the cardiac surgeons. During that time, the cardiologists were not used to work with anesthesiologists. They were used to have their technicians in the Cath lab, and they did not communicate with the case. Maybe they talked about what they will do in the evening or whatever, but they don't have to communicate with the technician. And that was the thing what we learned in the first months and years, that we have to force everyone in the team to communicate. And a lot of anesthesiologists, and that a lot of them are not the one who really stand up loud and communicate. So they just mention something, and they are not really insisting if they don't get an answer. But that is crucial during that whole procedure, that if you tell the cardiac surgeon or the cardiologist something, that he will reply and vice versa. So if the cardiac surgeon or the cardiac interventionalist tells you something or asks you something, you have to reply in that way that he also recognized. I think that is, for me, the main message of the whole talk in the first four slides. And you know that every discipline has a different function, different lifestyle, and different attitude, I would say. And I think the attitude